Your interpretation and your understanding of the relationship between the American Society of Colon and Rectal Surgery and the United Kingdom and their association. But on a personal level, just tell me briefly, how did you get involved in colorectal surgery, Robin? And who are the individuals that really stimulated you to move in this direction?
Entirely by chance that I became a colorectal surgeon. In the United Kingdom, back in those days, and I'm talking now the late 70s, early 80s, you had to do a period of research, and you had to get funding to do the research, and that was really the key. So I tried to get funding in melanoma, metabolic water, pain, and eventually someone came along and told me about a defunct project called the Large Bowel Cancer Project, because Peter Fielding had left and gone across the United States, and did I want to take it on? And of course I said yes please. And so it all really came out of chance, getting involved with the Large Bowel Cancer Project, where we got involved with the first statistical analyses using Bayes' theorem, Cox regression, multivariate analysis in colorectal cancer, and had a very large database to work on.
And where was your basic training in medical school? Just a brief history.
I was an undergraduate at the Royal Free Hospital, and I did my postgraduate training at St. Mary's, both in London. Because of the link with Peter Fielding, he then invited me to apply to the American Society of Colon and Rectal Surgeons as a young trainee, to be able to come over and spend 2 or 3 weeks, which now I think you call a traveling fellow, and this is a slightly older group. And I had funding from the American Society, from the Royal Society of Medicine, and actually the Royal Society in London, to come out and go around a number of places in the United States to look at private practice, to look at major clinic practice, to look at county hospitals, to look at the comparative type of healthcare in the US. It was a great experience for me.
Care to give us just a little synopsis of how you view this relationship between St. Mark's and the American Society of Colon and Rectal Surgeons?
Well, others will be able to describe it better than me, but St. Mark's was the first colorectal hospital in the world, but it wasn't the first place to establish a society. The first society was the American Colon and Rectal Surgeons Society. I think that the British Society of Colon and Rectal Surgery came much later than the American Society. We had a section at the Royal Society of Medicine which didn't really represent the country as such, but was a local club. And that, of course, went way back, and I'm not sure which one came first in terms of the American Society or the section of coloproctology.
You've been around for 20-some years. What do you think the greatest advances have been during that period?
I remember when I was interviewed for the 4th time to become a resident surgical officer at St. Mark's, having failed on the 3 previous occasions. And I was asked by John Nichols, who co-invented the pouch, what I thought at that stage was the greatest advance in colorectal surgery in recent years, by John. And I looked at him and I said, metronidazole. And he wasn't happy. So I don't know, in terms of the best advances in my time, I think the shortened hospital stay for virtually everything has been a major advance. When I was a resident surgical officer, 10 days in hospital for a hemorrhoidectomy. We used to admit the major abdominal cases 2 days before surgery, and the minors came in 1 day before surgery. So I think those sorts of things have been the major changes. There has been a sea change which is happening now between trying to cure things surgically and managing people with their problems. The managing people with their problems is a medical approach where you have someone with a chronic disorder and you manage them, you help them live with it. You don't get rid of it, you manage it. And that now creeps into some types of cancers where people live alongside their cancer. And we're sort of seeing this in the frontier areas, for example, in the anorectal area. Do we seek to cure a patient of their anal fissure, or do we try to help them live with their anal fissure? Do we seek to cure a patient of their anal fistula, or find a way that they can live with their anal fistula? And these are very different approaches that are coming in.
I couldn't agree more. As you look into the future, what operations in our field do you think will become obsolete? The operations that you were taught to do, and what operations do you think are going to become obsolete?
I think open surgery is going to be here to stay because things go badly wrong sometimes, and you cannot totally get rid of the open surgery. In fact, in the longer term, one of the most difficult things is how are we going to train the open surgeons, because they're all going to be laparoscopically trained, and the most difficult cases will be handled open. I'm not quite sure how we'll do that. We're moving more and more towards conservative surgery, so you could imagine that those ablative techniques, for example, lay open a high anal fistula, may be an area that will go by the wayside. But it should only go by the wayside when we've shown that the alternatives work, which we haven't yet shown.
What do you consider to be the next great development in colorectal surgery or in diseases that involve the colorectum?
I think it was Henry Ford said that, if you tried to design the next generation of transport, you would have had a faster horse. And the thing is, you can't really work out where the new advance is going to come from. We've looked for the equivalent of the Helicobacter pylori that might be behind anal fistula or Crohn's fistulas or things of that sort. We haven't found it yet. And I think it's understandings of that sort that really transform treatment. If you think of gastric ulcers that were being operated on all the time, and of course not now because it's an antibiotic responsive disease.
But I'd like to know, how do you become a colorectal surgeon in the United Kingdom today?
Well, I'd start off and take the big view. There is Europe, which has digestive surgeons. And the digestive surgeons deal with solid organ as well as luminal organs, and they walk hand in hand with the gastroenterologist up and down the GI tract. In the United States, you've got colon and rectal surgeons, you've got upper GI surgeons, you've got hepatopancreaticobiliary surgeons. The United Kingdom followed the American model, but there are problems. And the major problems we're faced with today is that emergency surgery is largely abdominal. And the European approach is in many ways a more favorable approach for managing major abdominal emergencies. The other thing is that if you want to manage patients side by side with your medical colleagues, then it's useful if you walk up and down the GI tract as they do, because they walk up and down the GI tract. You will find your gastroenterologists are not just colorectal gastroenterologists, they will be doing other things as well. So it is quite a difficult issue, that one.
Do you have a comparable organization in the United Kingdom to the American Society of Colorectal Surgeons? And how do you become a member of that? Who is qualified to become a member of a comparable? How does that work?
When we first founded the Association of Coloproctology of Great Britain and Ireland, one of the big questions was, how do you define a colon and rectal surgeon? And we decided that in the beginning it was one who signed his name on the piece of paper saying he wanted to join the society. The situation has moved on quite a lot from there, but we still haven't passed on all of those people who signed in from the general surgical background. Nowadays, I think colon and rectal surgeons will have gone through a fellowship program in colon and rectal surgery, and they will also usually have done a fellowship program in laparoscopic surgery. So they are usually people who've done a double program. It isn't absolutely required, but I think it will be so in the longer term.
The interest in colorectal surgery is tremendous in your country.
It is. I mean, colorectal surgery is a very big area. We have to develop emergency surgery in order to maintain the American type approach of upper and lower GI surgery and so on. If you're going to not develop emergency surgery as a specialty, then your surgeons, your abdominal surgeons, will have to be able to deal with both ends of the GI tract. So this is one of the major things we have to consider. And emergency surgery has its benefits. Young people want to go and do it. They find it very exciting. Older people not so sure that they want to do it. And there's not so much private work in doing emergency work. So you'll have to fund it differently. Perhaps the future leaders of the profession in the hospitals will come through the emergency surgical route. They will be in the front line, and then later they will be doing the post-operative, post-take ward rounds and the surgery that is built up from the emergency take, and then they'll go into management, and that's where the hospitals will probably be led from in the long term.
Your area of research through your life has been primarily in what areas, and you care to comment on those?
Well, I focused down really in my professional career to inherited colorectal cancer and polyposis syndromes and problems around the anal rectum. And the areas that I've had a particular play in have been development of non-surgical treatments for anal fissure, the management of anal fistula, and the management of rectovaginal fistula. And on the research front, I've been trying very hard to be conservative, that is, not to cut. But in the clinical sphere, I think laying open fistulas and doing sphincterotomies are probably superior at the moment to the alternatives.
Anything you want to say particularly about the relationship between St. Mark's and St. Mark's and the American Society of Colon and Rectal Surgery, that goes all the way back to wasn't the first combined meeting when in the 20s, 1929?
I think it was. I seem to remember that people would travel over on the boat, and
Right.
They would come over 4 or 5 days to New York, and then they would stay and have the meeting and then travel back again. I was going to say, I think for the record, what I would say, in my lifetime, the major ambassador for colorectal surgery worldwide has been one Dr. Stanley Goldberg. And I think that everyone around the world will see that as really being the person who united worldwide colorectal surgery.